Okay, we'll get started. Welcome everyone to the SADS Foundation's 9th webinar in the Living with SADS series tonight on arrhythmogenic right ventricular cardiomyopathy. I'm Marcia Baker. I'm the program director for the SADS Foundation. Before we begin the webinar, a couple of reminders. One, please keep your audio muted during the presentation to improve the sound quality for all. You'll see on the lower bottom screen, if you put your cursor on the bottom, you can click that mute button and just clicks on and off. Everyone entered in mute. Following the presentation, we've allotted plenty of time for questions and answers. You may type your question in the chat box anytime during the presentation, and we will address those at the end. Our webinar is being recorded, and it may be accessed later on SADS Foundation's YouTube channel. We do have live transcript enabled on the bottom of your screen. You'll see that icon. So if you don't want to see the subtitles, you can click on the live transcript icon on the bottom of the screen and hide the subtitles if you don't wish to see them. Now I'd like to introduce our speakers today. Dr. Hugh Calkins is a professor of cardiology and director of the electrophysiology laboratory and arrhythmia service at Johns Hopkins Hospital. He is an internationally recognized expert on catheter ablation, atrial fib, syncope, and arrhythmogenic right ventricular dysplasia and arrhythmia management. Dr. Calkins is an associate editor of the Journal of Cardiovascular Electrophysiology and is on the editorial board of many other cardiology journals. Dr. Calkins has published more than 500 articles and book chapters on a large variety of cardiac arrhythmias. His research has focused primarily on catheter ablation, atrial fibrillation, syncope, and ARVC. Dr. Calkins has also written extensively on most aspects of heart rhythm disorders and their treatment. Joining him are Brittney Murray and Tichnell, who are genetic counselors at Johns Hopkins and provide education and counseling to patients and family members affected by inherited heart conditions. Both are actively involved with the Johns Hopkins ARVC Program team. And now I'd like to turn it over to Dr. Calkins. Welcome.
Great. Well, thank you, everyone. And it's great to be with you this evening or whatever time it is where you're calling in from. I want to thank the SADS Foundation for hosting this webinar and for supporting our effort to increase awareness of ARVD and to try to stamp out this disease someday. So I'm going to start by giving you a brief overview of ARVD, and then we're going to have a lot of time for questions and answers. And Crystal and Brittney have been working, as part of the program for nearly 20 years, and we have a lot of experience. So hopefully we'll be able to address many, if not all, of your questions to the best of our ability. So when you think about ARVD, what I'm going to do in the next half an hour is give you a little overview of ARVD. I'm going to touch on the genetic basis, but I should note that I'm not a genetics expert, but Brittney and Crystal are. I'm going to spend a lot of time talking about clinical presentation and follow-up, management and treatment of ARVD, and then we'll wrap things up. We get some research support from Boston Scientific. So ARVC is a genetically determined or inherited heart condition characterized predominantly by replacement of the right ventricular myocardium, the tissue of the right ventricle, with scar and fat. So the muscle itself disappears and fat and scar replace it. And clinically, ARVC shows up mainly as heart rhythm problems, either sudden death, syncope, palpitations. We now know that even though ARVC historically was considered to be a disease of the right ventricle, we now know that ARVC also can involve the left ventricle. In some patients, particularly those with certain types of mutations, ARVC is a predominantly left-sided disease, so it can affect both the right ventricle and the left ventricle. Now, this is a heart of someone that was 34 and was transplanted for ARVC, and you're looking from the top of the heart down. But just, this is the left ventricle, the main pumping chamber, and this is basically normal. You can see this looks like normal, healthy heart tissue, whereas the right ventricle, this chamber, is extremely dilated. It's much bigger. And if you look at it, there's almost no muscle tissue left. It's all replaced by scar and fat. And the arrhythmias that occur in ARVC tend to come from the right ventricle, which has all this scar and fat instead of smooth, normally working muscle cells. Now, it's a rare condition. It's about 1 per 5,000 in the United States. That compares with hypertrophic cardiomyopathy, which occurs in 1 in 500. It's a little bit more common in men than women, but the main determinant is whether you inherited a mutation and how much exercise you do, and we'll go over that later. It accounts for about 20% of sudden deaths in young people and 5% in the US. If there's a headline in your paper about a basketball player or a football player dropping dead on the football field, hopefully being resuscitated, it's about the third or fourth most common reason they'll find when they try to figure out why that tragedy occurred. Now, this is a slide of a study done by our colleague Chris Semsarian. They looked at autopsies of people, young people that died suddenly. And the point of this is that ARVC accounted for more deaths. This is the number of deaths in this study in Australia than hypertrophic cardiomyopathy. Even though hypertrophic cardiomyopathy is 10 times as common, ARVC in our mind is far more important because it kills more people or causes more cardiac arrest. So it's certainly a very important condition. Now, when it comes to diagnosing ARVC, we rely on this document put together by Frank Marcus, who recently retired, but he's from Arizona. And a whole group from all over the world came together to come up with these diagnostic criteria for the disease. And they're shown here. I'm not going to go into this in detail, but the point I want to make is making the diagnosis of ARVC is not easy. And we always tell cardiologists and electrophysiologists that they should be slow to make the diagnosis. And you have to realize there's no one diagnostic test. You can't diagnose it with an EKG. You can't diagnose it with an MRI. You can't diagnose it with genetic testing. It takes all of the above. You got to look at the results of the EKG. You got to see if they have any arrhythmias. You have to examine the family history, the results of genetic testing. Occasionally we'll do a heart biopsy. So again, there's lots of different tests that come into the evaluation of a patient for possible ARVC. This is an EKG of a patient with ARVC, and I know none of you are cardiologists, or maybe some of you are cardiologists, but you should be aware that the EKG is a very powerful tool to sort of screen patients for possible ARVC. And this is what's called the 12-lead EKG. So this is the heart rhythm looked at from 6 different angles. But we always focus on leads V1, V2, V3, which are the leads across your chest. And what we can see is what's called T-wave inversion. This part of the QRS is upside down in leads V1, V2, and V3. And that's a major criteria for ARVD. If you have an EKG like that, you get half the way towards making the diagnosis. The other thing you see is if you look at this little squiggle, the QRS, it goes up, then it goes down, then it goes back to baseline, but it takes a while. There's a couple little bumps here as it tries to go back to baseline. That's an abnormal pattern, and that is also a criteria for ARVD. So that gets you 1 point. So this EKG alone, if I see it, I know almost for sure that patient has ARVC. I have to confirm it with other tests and so forth, but it's highly suspicious. Now, cardiac MRI is a wonderful way to examine the heart. While it's beating, you can look at the size, you can look at the function. You can also see if there's scar, if there's fat. And this is one of the most important diagnostic tests for ARVC. But it's also a very tricky test. It's hard to do the scans. It's very hard to interpret the scans. Now at Hopkins, where we see 5 to 10 ARVC patients a week, our radiologists have become world famous in interpreting MRIs and are extremely skilled at it. But at many centers in the United States where they see very few of these patients, it's not surprising that whoever's looking at the MRI scan may have trouble figuring out whether it shows evidence of ARVC or not. And it's for that reason that the MRI is a common reason for inaccurate diagnosis of ARVC, but I won't go into that in more detail. So let me switch a little bit to the genetics. And again, I'm not a geneticist, but ARVC is an inherited disease, and most of the mutations, most of the genetic abnormalities are in what's called desmosomal proteins. Now, this little cartoon shows two heart cells. This is where the two heart cells join, those two train track like white things. And these colors are the different proteins or bolts that hook the cells together. And what the bolt is shown here. So plakophilin 2, the green, is the most common genetic abnormality in ARVC, this part of the bolts. Desmin is another cause. So again, most patients with ARVC will have a mutation in the bolts, these desmosomal proteins. And a simplistic way of thinking of the mechanism of ARVD is you're born with bad bolts. You exercise a lot, which pushes stress on your heart. The cells rip apart, the cells turn to scar and fat, and that causes heart rhythm problems. That's a very simplistic way of thinking about it, but I think one that helps us explain a lot of what we know about the disease. Now, this just shows that today, if you do genetic testing, you'll find a mutation in about 2/3 of patients who have ARVC. And the most common is plakophilin 2. That's what you're going to hear most commonly. And these other ones, desmogliin, desmoplakin, desmocolin, and so forth, are much less common, but they also are important. But by far the most common, and the one that we see in the United States and in Europe, is PKP2, plakophilin 2. ARVC is inherited as an autosomal dominant condition, meaning there's a 50-50 chance you'll inherit the mutation from your parents. And if you get the mutation, that doesn't mean you're going to get the disease. It has something called incomplete penetrance, which means just having the bad mutation doesn't mean you're going to get the disease. It takes other factors, probably other genetic abnormalities, but also a lot of exercise. And we're going to talk a little bit more about that later on. So now I'm going to shift to my favorite topic, which is the clinical aspects of this condition. And again, I've probably seen well over 500 patients, maybe 1,000 patients with ARVC over time over the last 20 years. So I've become quite experienced at seeing the different ways this condition presents. Now, this is a paper that we wrote 15 years ago. When we had 100 patients with ARVC, 31 were diagnosed on autopsy, they died, and 69 diagnosed while they were living. And you can see their average age was about 32 when they were diagnosed. About half were men, half were women. Many were athletic, and they showed up with palpitations, skipped beats, or racing heartbeats, passing out, sudden death, or aborted sudden death. Some patients were asymptomatic and picked up perhaps with routine EKG screening before participating in a sport, for example. Now, this shows a figure from that paper, and this is what's called the Kaplan-Meier curve. It shows years of life on the horizontal axis. So here they are, 80 years of age, and here you are just born. And this shows from 0 to 100% your freedom from different symptoms. And the point of this slide is that ARVC, the symptoms, which are shown in this dark line, correlate with arrhythmias, and they start around the age of puberty, around the age of 12, 13. That's sort of the youngest people ever to show up with ARVC are teenagers, young teenagers, and that over time, the symptoms increase. So, and the symptoms are caused by VT. Sudden death is less common. And then above here is heart failure. Heart failure we're recognizing is more and more important in ARVC, but it's something that occurs later. Only usually decades after you're first diagnosed is when the heart failure shows up. And that's becoming a more important problem now because we're keeping people alive with implantable defibrillators and catheter ablation and other treatment options. Now, this is a slide of patients in our series that had a heart transplant. And heart transplantation is extremely important in ARVC when you end up with severe disease. And each of these lines is a patient, and it tells the patient's story when they first got symptoms. Like this patient was extremely lung. When they got diagnosed is when the line turned solid. Here, this patient got diagnosed at 33. And then it shows the various events that happen: VT, catheter ablation, defibrillator. But the point of this is the symptom onset in these patients that needed transplant was average of 24 years of age. And they were transplanted at the age of 40, so 16 years later. And they mainly were transplanted for heart failure because we're pretty good at treating the heart rhythm problems these patients face. Now, more recently, we've collaborated with our colleagues in the Netherlands, Richard Hauer and his colleagues, and we put together a series of 1,001 patients and family members. And we basically saw the same thing. We saw that ARVC shows up after puberty, that arrhythmias are the most important symptoms, and that the need for transplantation occurs many years later. If you have a mutation, you show up at a younger age than if you don't have a mutation. And so now we'll move on to management. When you think about management, I think about a 5-legged stool. It starts with making the diagnosis. You don't want to miss the diagnosis, but you don't want to diagnose people with this condition who don't have it, because it has very major implications in terms of their lifestyle and treatment. Once you made the diagnosis, you've got to determine, is this patient at risk of a cardiac arrest? Might they drop dead? And do they need to be protected with a defibrillator? That's a critically important question that we focused a lot of our research on. Then once we decide if they need a defibrillator or not, we want to make them feel well. We want to minimize their symptoms, minimize the chance the defibrillator goes off. Then we have to remember this is a progressive condition and heart failure is common. We want to prevent progression. What can we do to do that? And then we want to remember the family members. Every first-degree family member, siblings, parents, need to be screened for ARVC because it's inherited. And when you find one individual with ARVC, there's family members, there's brothers and sisters that may have it, and you have a chance to diagnose it before it causes a problem in those other siblings or parents or children. So let's talk a little bit more about the diagnosis. You need to do a comprehensive evaluation. You take a clinical history, a family history, an exercise history, a physical exam, EKG, Holter, MRI. I crossed out signal average EKG and stress tests because we really don't find them to be of much use. We recommend genetic testing when you suspect the diagnosis. We use those criteria that I described earlier. And then we also now know that ARVC can show up as myocarditis. If someone shows up with chest pain and they have what's called enzyme elevations of troponin, that may be due to inflammation in their heart, myocarditis, or it may be ARVC showing up as myocarditis. So that's something also to be aware of. Once you made the diagnosis, we've got to decide, should they get a defibrillator? Well, the risk factors for a sustained ventricular event include a prior history of a cardiac arrest or sustained VT. Proband status means, are you the first person diagnosed in your family with a condition? If you are, you tend to have more severe disease because your other relatives get a major criteria for that other individual being affected with ARVC. So proband status, if you're the first person diagnosed, you're at higher risk. Male gender, we know testosterone is a bad actor in young people with ARVC. There's more young men who die suddenly than young women. Extent of the disease, the more severe disease, the higher the risk. We love Holter monitors, putting on a 24-hour monitor and seeing how many PVCs, extra beats you have. If you have less than 500 or less than 1,000, that's pretty good. As you get over 1,000, risk goes up. Once you get to 5,000, 10,000 a day, the risk of having a sustained arrhythmic event goes up very dramatically. So we pay a lot of attention to that. Cardiac syncope, have you passed out? Now, we don't talk about fainting. You know, you see blood, you're singing in the choir and it's hot and you have a swooning episode or a fainting episode. That's what's called vasovagal syncope. That's not what we think about. What we're thinking about is cardiac syncope. Cardiac syncope means you're walking along down the street or you're exercising, you abruptly collapsed in like a split second, you hit the ground. Oftentimes you injure yourself. You may break your glasses, break your arm, whatever. It's a very abrupt syncope where you can't protect yourself. And then you wake up and you're fine right after. But that kind of syncope really points towards an arrhythmia. And with ARVC, if you have that kind of passing out episode, you're at high risk. and we're going to likely recommend a defibrillator. Exercise plans. Exercises increase arrhythmic risk. If you plan to keep exercising, your risk goes up. We can do what's called an EP test. We can put catheters in the heart and test your heart electrically. That can provide other information. And then at the end of the day, it's about preferences and values. Some patients hate the idea of a defibrillator and will accept a 5%, 3% annual risk of a cardiac arrest. Other patients are unwilling to accept even a 1 in 1,000 risk of a cardiac arrest in a year and would have a much lower threshold for getting a defibrillator put in. So recently we've developed a calculator. So you can go to your iPhone and your computer, and you can put in a program we've developed where you can come up with what your risk is. And the variables that we're going to have you enter, and I'll show you on the next screen what the name of that, where you can find this risk calculator, are male, sex. If you're a male, you're higher risk. That means your hazard ratio, your risk goes up. If you're younger, your risk is higher than if you're older. If you're 70, you've obviously already lived 70 years. Your risk of dying the next year is probably less. If you're 13, you've only lived 13 years, and so the risk is probably higher. Have you had cardiac syncope? Do you have non-sustained VT? How many PVCs do you have? And how abnormal is your EKG in terms of T-wave inversions, and what's your RV function? So this is the risk calculator. If you go to www.arvcrisk.com, you can put in, you can see here, you can put in gender, age, whether you passed out, non-sustained VT, and so forth, and it will give you your 5-year risk of a sustained arrhythmic event where you go into sustained VT or you go into a cardiac arrest. So that's a very useful tool to help understand why you should or should not get a defibrillator put in. When it comes to a defibrillator, there's two main types. There's the standard type, put under the skin, the wires thread in a vein under your collarbone into your heart. These devices typically last 10 to 15 years in terms of the battery. They've been around for 30 years. They're very reliable. They can stop the VT, the arrhythmia, by pacing, so it has some real advantages. The problem is these wires can break and they can get infected. And if they break or get infected, it's a big job to pull them out. There's some risk to that. So the other option is a subcutaneous defibrillator that goes under the skin. Here it's not under the skin, but it goes outside the rib cage, under the skin, and the wire is tunneled under the skin over your clavicle. So it's not in the heart. It's not squeezing with every heart contraction. And yet it provides equally good protection from a cardiac arrest. And in general, if you have very mild disease and you're putting the defibrillator in prophylactically, we commonly will recommend the subcutaneous device if you screen in for it based on your EKG features. If you have more advanced disease or you've had sustained VT, we'll recommend the endocardial device, but we can talk more about that later. So once you've decided about putting a defibrillator in or not, then we want to focus on quality of life and preventing that defibrillator from going off. So what can you do? You can stop exercising, particularly competitive endurance sports, and take a medicine called a beta blocker that blunts adrenaline. You can take other medications called ACE inhibitors. There's antiarrhythmic medications you can use. And then there's catheter ablation, where you go in and cauterize the VT from both the inside of the heart and the outside of the heart. In terms of the exercise recommendations and why we recommend you don't exercise if you have ARVC, you have to remember ARVC is a disease of the desmosomes. The desmosomes hook the cells together. They're the bolts. When you exercise, pressure in the heart increases and you put stress on those bad bolts, and that increases the progression of the disease. Most ARVD patients who develop the disease, particularly at a young age, are high-level athletes. Exercise is a common trigger of an arrhythmia or sudden death. Many people will die suddenly while exercising. There's now been lots of studies in mice where if mice exercise, they get ARVD if they have the genetic abnormality. If they don't get it. And now there's lots of clinical studies from all over the world showing exactly that. Now, this is the first study that was actually done by my colleague, Cindy James, based on our patients. We took 87 patients with a mutation, And what we found is this is hours of hours of exercise per year prior to presentation. And on the vertical axis is what's the chance you are diagnosed with ARVD. So if you didn't exercise much, 0 to 134 hours per year, only about a 28% chance you get ARVD. These are all patients with a mutation that puts them at risk. But if you exercised a lot, 510 to 2,600 hours per year, the chance of you being diagnosed with ARVD was 85%. So a striking difference. And similarly, if you were an athlete versus not, if you were an athlete, your chance of having a sustained arrhythmic event is much higher than if you weren't an athlete. Same with heart failure. If you're not an athlete, the chance of getting heart failure is about 0. If you are an athlete, it goes up very dramatically. Now, this is just a slide that I think is quite helpful. It sort of tells you what kind of exercises we think are good. Good exercises, if you have ARVD, are yoga. Down here, green, very little metabolic equivalent. These are very relaxed sports. Canoeing, rowing for pleasure. Sailing is good. Walking, golf. Things that we encourage you not to participate in are competitive cycling, cross-country skiing, soccer, running, basketball. I think you get the picture. So these high intensity sports, do them never or rarely. Yoga and walking and golf regularly is fine. So in terms of catheter ablation, catheter ablation is an important way to treat patients with recurrent sustained VT or defibrillator. The defibrillator is going off who have ARVD. It's a pretty tricky procedure where it's really critical that whoever's doing it has lots of experience. And it oftentimes takes ablation both on the inside of the heart and on the outside of the heart. My colleague, Harry Tandry's, I think perhaps the foremost expert in the world doing this procedure, has done over 250 of these procedures with very good results. These are just some of our recent results: 220 procedures, 116 patients. And you can see, by these numbers, you can see it's not uncommon to need a second procedure. But if you're willing to undergo one or more procedures, at the end of the day, about 70% of patients are free of recurrent VT as a result of catheter ablation. And most importantly, in skilled hands, it's a very safe procedure, even though it's an extremely complex procedure. If you've done hundreds of these, you become much better in terms of your safety profile. So if catheter ablation fails and drugs fail, what do? We now know that the right way to go, and again, Dr. Tandry has been leading this effort, is what's called a sympathectomy, where you cut the nerves to the heart. You do what's called a bilateral sympathetic denervation. And this just is a paper we published describing how effective this is. So we're seeing more and more patients where they fail VT ablation, they end up getting a sympathectomy, and almost always we can get their arrhythmias controlled. So then I'm going to move on to preventing progression. You have to remember that this is a progressive disease. No one's born with it. It doesn't show up till you're a teenager. And then over time it gets worse. And this is a study we did looking at echoes 5 years apart in about 80 patients, showing that over time, our heart function goes down, the heart dilates, that it's progressive. And I think we all know that. Now, my colleague put together a recent study of heart failure and found that of patients in our program, 49% had heart failure over time. So this is extremely important. And it's something that oftentimes doesn't show up till 10 or 15 or 20 years after first diagnosed. But as we keep patients alive, they live to develop heart failure. And then so we have to pay more attention to trying to prevent it. So what can you do to prevent it? Stop exercising. We've talked about that. Take beta blockers, take an ACE inhibitors. And we have one of our colleagues, Nisha Galatra, is a heart failure specialist that works with our ARVD patients. So let me just wrap up this high-level overview is to remind you that ARVC is rare but exceedingly important. It's a disease of desmosomal dysfunction. It's hard to diagnose. That's one of the roles of our program. We see lots of patients for a second opinion about do they or don't they have ARVC. We've taken out about 20 defibrillators in patients who were told they had ARVC and they didn't. that's a happy day when you can take the diagnosis away from someone. We now have a risk calculator to help guide decisions about a defibrillator. If you're high risk, we would recommend that the defibrillator be implanted. Catheter ablation is important. You got to remember this is progressive. You got to remember how important exercise restriction is. And it's also an exciting time in ARVC where there's lots of research going on of new therapies, gene therapy, and so forth is all underway. And so we're hoping someday to cure this condition. So I'm going to stop there and thank all of you for participating. I want to thank Crystal and Brittney for being here, and they're going to help lead the discussion. And I'll stop at this point. Thank you.
Thank you very much, Dr. Calkins. And I'll turn it over to Crystal and Brittney to kind of facilitate the questions. We've had quite a few come in already. So
yeah, I've been keeping tabs. Okay, so let's start off with what % of ARVC patients are pacer dependent?
Almost no patients with ARVC are pacemaker dependent. ARVC is not a disease of the conduction system. So unlike conditions like cardiac sarcoidosis, where the heart block and the conduction system can be involved, ARVC spares the conduction system. So it's basically not an issue with ARVC patients.
And then Brittney, I'm going to pose this one to you. Any new genes identified for those that had previously been tested and were negative?
Yes, Dina. So broadly, I'll answer the question for the group, and then Dina, you and I can talk later. But broadly, yes, we have new genes that have been identified recently. In fact, I was just emailing with one of our physicians that I was a patient I saw in 2016. And he asked me if I thought that repeat testing was reasonable. And there are about 3 new genes, which we're detecting in a minority of cases, which are reasonable to retest, especially since genetic testing is really cheap right now. So it's very doable. But this is, again, these 3 new genes account for maybe 3% of cases each. So it's not like, oh, now we've discovered 100% of ARVC now. But yeah, we just had a publication accepted last week in Circulation on a new gene, CDH2, that's not even clinically available for testing yet. So yes, new genes are coming all the time. And if you have further questions about that, you're always welcome to chat with me directly about it.
Any new information specifically related to females correlating hormonal issues and a higher instance of PVCs or VT? So I think we know in general with hormonal changes, there is an increase in PVCs, but I know Dr. Farhat was doing some research on this. Hugh, I don't know if you know any more details.
Well, Dr. Farhat Duru from Zurich they've done a lot of work on sex hormones and how that affects ARVC. And, my recollection is androgens, the male sex hormones, but women can have androgens too, play, an important role in arrhythmogenesis and ARVC. But if you Google Farhat Duru, you probably can find that paper. We can help you find it. But they wrote some beautiful papers about hormonal levels in ARVC, and I think one of the links with exercise is that if athletes have higher androgen levels and testosterone levels than non-athletes, so that's another way that exercise impacts ARVC.
How can you differentiate between ARVC and damage caused by viruses?
Oh, I mean, if there's a number of different ways with ARVC. When you think about ARVC, it starts with EKG, and certainly the EKG of a patient with ARVC would be very different than someone who had myocarditis or other type of cardiomyopathy. So the EKG is one way. The MRI pattern is another way. Myocarditis has a certain appearance on cardiac MRI. And so again, this is where the MRI experts play a huge role. I think those are two of the most important things. An interesting question is, what's the role of a endomyocardial biopsy, taking a snippet of the heart? And in general, we found it to be a very unhelpful test, because if you do a biopsy and you see inflammation, that doesn't mean one thing or another. And in order to diagnose ARVC, you have to meet certain criteria in terms of how much of the tissue's gone. So it's not a very helpful test. I think we're so good with good high quality MRI imaging, the EKG features of these disease. That's really the crucial thing. And then genetics. If you have a patient that appears to have myocarditis, but they have a mutation in desmoplakin, well, then I think you'll clearly call this a ARVC due to desmoplakin. Brittney, do you want to comment on that? You've had a lot of interest in these patients.
Yeah, actually, it's something that has come out over the last, really the last 5 years, but really grasped a lot of national attention, in that these big inherited heart disease centers are really recognizing that something that we suspected for a long time, but overall that there's this rampant overdiagnosis of myocarditis, and that actually many cases of ARVC are presenting with something that looks exactly very similar to myocarditis, and you can have enzyme elevations, things like that. But we know that ARVC is an inflammatory disease. When the desmosomes are breaking apart, it causes an inflammation response in the heart. So myocarditis literally just means heart inflammation. And so they look very, very similar, and they can be tricky to diagnose. So this is something at our center, and certainly at a lot of other inherited heart disease centers, we're really trying to get the message out about the importance of genetic testing in young myocarditis patients, especially myocarditis patients who have recurrent episodes. And so there's a host of features that can really differentiate the two, for sure. I wanted to just follow up. I just saw one question come in at the end to follow up on the PACER question.
Yeah, exactly.
And I think it is important because this is something we discuss in clinic all the time. This person mentioned that in regard to the pacemaker question, they were implanted with a dual chamber device because of a low heart rate. And so this is something that we often discuss in clinic, that's not something that we typically recommend. So I didn't know if you wanted to comment on that.
Yeah. We are very much against having 2-wire defibrillators, because the more wires you have in the heart, the more things there are to break or get infected, and there's less room for other leads, if the ones you have do break. So it's very rare that we'll recommend a dual chamber defibrillator. Now, many patients with ARVC are athletic, and so they have a low resting heart rate, but a heart rate of 40 or 50 in a young, healthy person is perfectly normal, just because they're in shape and they're a young, healthy person. When they walk or run or whatever, their heart rate increases normally. There's nothing wrong with their own body's pacemaker. So, we think, it's a mistake to put in a 2-wire defibrillator in someone like that. I mean, rarely there's someone that also has fairly, pronounced slow heart rates and they're having VT, and you want to put them on an antiarrhythmic, and the antiarrhythmics all slow the heart rate. So there's times where, it's appropriate, but it's probably less than 1 in 20 patients. Most patients, 1-wire defibrillator is all you need. I should note that there's been a movement in the EP field. I mean, 10, 20 years ago, we always thought, 2 leads are better than 1 because you can have better discrimination. And there was sort of a happiness with sort of always putting in a 2-lead device. I think over time, we've learned that's the wrong approach. One, adding the second lead can add complications, acutely, lead dislodgement and so forth, but also can cause problems down the road. So we've really had a shift in how we approach this. But for patients who had their dual chamber defibrillator put in 10, 15 years ago, I think we really didn't know better then.
Here's a question related to one of your new hot topics. Since hot phases can happen at various times, do we monitor PVC load with the quarterly device monitoring, since Holter monitors are usually only prescribed once a year?
The answer, this is sort of an area that we're starting to focus more on, is what additional information can we glean from the defibrillators in terms of a PVC counter? Until recently, not all manufacturers allowed, they would track non-sustained VT, but they wouldn't necessarily count the number of PVCs. So it was dependent on the manufacturer, the model, and a million different things. And to be quite honest, we haven't really focused on this a lot. But recently a patient came in, they said, look, I have this device and it counts PVCs. Why aren't you paying more attention to it? And he made us realize this is something we got to do some research on and take advantage of that. Clearly, if you're getting your quarterly ICD checks and your defibrillator model happens to report out the number of PVCs you've had, certainly the amount of non-sustained VT you had, that's certainly a marker of arrhythmic risk and disease activity. So if you've started picking up your exercise program and at the same time your next defibrillator check, your PVCs went up tenfold, well, that's probably why, and that's probably important to ratchet back your exercise.
This next question, Brittney, you'll probably have some input. How do you fund heart testing of your children? Insurance companies don't appear to consider EKGs and Holters a coverable benefit. And I haven't really seen that. I think sometimes if they require authorization or a reason why, the minute you mention there's a family history of a heart condition that might cause sudden cardiac death, they're quick to cover an EKG and a Holter. But have you had any experience with that?
I mean, I know they will fight us on MRIs every time. And actually, we've had really good success. I think in the entire history of me with the program, we always have to end up doing peer-to-peers and argue with them in appeals. But once Dr. Calkins talks to the medical director, we've never, I think maybe only once or twice, had an MRI denied. I have never in our program had a Holter and an EKG denied for family history of ARVC screening.
Yeah, these insurance companies are terrible. I mean, it's just awful that they love collecting money from payments, but they hate paying for tests. So it's just incredible. But, Brittney and Crystal, some will need an MRI and we have to get pre-approval. And so there I have to be on the phone for 20 minutes talking to this medical director who knows nothing about ARVD to quote unquote approve it. They're just trying to put all these roadblocks in, hoping you'll run out of steam and give up. But at Hopkins, we never give up.
Here's a couple of questions about the SICD. How close are we to the development and approval of an SICD with leadless pacing capability?
Oh, that's the idea of having a leadless pacemaker attached to a defibrillator it's getting closer to reality. I mean, I think most of you or you may be aware that we now have a leadless pacemaker you can put in patients. It's sort of a very simple device that's put in the right ventricle, but for very elderly people, it's a very nice option. So there's lots of these device companies are all trying to develop leadless defibrillators that will also pace using that kind of technology. I mean, I think it's a ways away. I think it's certainly 5 years away, but it's probably coming. But the pacing feature is really not that helpful. If you're having that much VT that you need a lot of pacing, you might as well get a VT ablation. And most patients don't have sustained VT. They just have these non-sustained arrhythmias that stop on their own.
How about advancements on the horizon for longer battery life for the SICD?
Oh, I mean, the SICD, we're now in like the second generation. So it's a relatively young device, and there's obviously a trade-off between the size of the device and the battery longevity. And they could increase the longevity of the device if they made it twice as big, but that obviously would be unacceptably big. So they're trying to optimize everything. I mean, I think battery technology is getting better now with all these electric cars and whatever. There's going to be more research into even better batteries. So I think over time longevity will increase. I don't think it will ever get to the standard endocardial devices where we're up to 12, 14 years. I find that hard to imagine we're going to get there, but I would like to think we'll get at least to 7 years.
And Brittney, someone asked about our DSG2 mice. Do you want to give an update on them?
Yeah, so Dr. Choco actually recently published some research on our little mices. So this is something that in the research article, it can sound quite dramatic, but he had an Italian fellow working with him something that you guys actually ask me all the time is about stress. And we know that ARVC, in ARVC exercise can, Dr. Calkins talked about that a lot, can trigger arrhythmias and progress the disease. But many patients ask me a lot about stress and psychosocial stress and anxiety and things like that. And this was something that there's a lot of research out there about kind of mind-body connection in arrhythmias. And so there was a paper that actually just very recently came out looking at, psychosocial stress and kind of fear and anxiety in the mice who have desmoglein 2 mutations. And so they have ARVC. And it was shown actually that the psychosocial stress, so having stress, led to more arrhythmias. This is something that I think as a no-brainer as a patient, you definitely know this. And the solution is not, and I say this in clinic all the time, the solution is not, quit your job because it's just, life is stressful. I think that this really underscored something that Crystal and I discuss all the time of how important it is to also manage your mental health and the mental side of this disease, which is a huge part of this disease. So making sure that you are in ongoing counseling. I think every single person with ARVC should be in ongoing therapy. If you need to talk to your doctor about medications in addition to therapy, come to support organizations like this. Talk to Crystal and I if you're really struggling and you want connected with someone one-on-one. Basically, a lot of evidence from the mice really showing at a kind of hormonal chemical level that anxiety and stress can increase your arrhythmias. So even more importantly, to attack those at the source.
If you're on a beta blocker and it controls your short runs of VT, but doesn't really decrease your PVC burden, should one consider a change in medication?
So that's a good question. So our thinking about that has evolved a bit. A number of years ago, we did research showing the more PVCs you have, the more chance you'll have sustained VT. So then we said, well, why don't we take patients who have lots of PVCs, and because we know there's very likely going to develop sustained VT, let's go ahead and do an ablation before they get VT. And so we did the ablation sort of prophylactically in these patients. And it turned out it wasn't that helpful. It really did not seem to have much benefit. So we've changed our approach where we wait to think about catheter ablation until patients are having sustained VT episodes. So I think the PVCs are really not critical, not very important unless, if there's over like 20% of all your beats are PVCs, that can make your heart function worse just because of so many PVCs. I think at a 20% level, we would probably put you on a drug or treat the PVCs. If you have less than that, less than 20%, less than 10%, I think the only reason to treat them with a medicine would be, for symptom relief if they're bothering you a lot because they're giving you palpitations. But otherwise, I think you can just let them be.
So let's talk about ablation. When would one consider an ablation? And given that some people have this diffuse fibrofatty changes throughout their heart, what is the focus of the ablation? How do they decide where they're going to target?
So in general, ablations, you have ARVD, you get a defibrillator, you start getting a shock for VT, maybe you get 2 shocks or you get paced out of it or whatever. That's when usually the next step is to try an antiarrhythmic drug, something like sotalol or flecainide. And if the medicine doesn't work or if it gives you side effects or if you prefer not to take medications, then you'd get the ablation done. With the ablation, 2 things are done. One, the entire inside and outside of the heart is mapped to look for areas of scar, diseased tissue. And 2, the VT is started up to figure out generally where it comes from. And in general, if the PVCs are coming from a common area would be what's called the outflow tract, then any scarred tissue in the outflow tract you'd burn to make it more homogeneous. And so instead of islands of normal tissue and scar next to each other, you'll just burn it all so it becomes a homogeneous big scar instead of a scar with lots of pock marks and normal tissue mixed with abnormal tissue. So it ends up being, when you have an ablation, a fair amount of tissue is ablated, but the tissue that is targeted is diseased tissue. So it's not that you're burning perfectly normal tissue, you're burning those areas that are already terribly affected by the ARVC.
Brittney, do you want to talk about any advancements in gene therapy to repair the desmosomal protein, specifically related to CRISPR?
Yeah, so there's multiple problems with CRISPR. It's just a multi-layered issue. So yes, absolutely. Right now, the technology exists. It has been done in a cell, in a dish, to use CRISPR to fix the desmosomal variant, and therefore to fix the protein. That technology exists in a dish. The problem is not that. The problem is in an adult, all of you, getting the body to reuptake or accept new cells and regenerate cardiomyocytes. It has not been very successful at all in most trials, even in a lab, because cardiomyocytes are not something that turn over regularly, like your skin cells and things like that. So the vector and getting them back in the body is the main issue with that sort of CRISPR technology. And so they're working really hard on that. I know in a lot of labs around the country, but it's a ways off for sure. I won't necessarily go into embryonic CRISPR. That is also a technology that exists. It is not something that the scientific community has agreed to use just because we have no idea the downstream effects of gene editing. There was, in fact, a scientist in China who did this kind of renegade. In fact, he was told he wasn't allowed to do it, and now he's in some sort of Chinese jail. So I won't really go into that. But the big thing I think that all of you guys are asking is, can I fix the mutation in my heart? And yes, we can take cells from your body and fix the mutation in a dish, but we have not figured out a good way to get it back into you yet. So TBD.
Hugh, what are the best measures to prevent heart failure, particularly in those who are diagnosed relatively young?
I think what we're starting to realize is the patients we're most concerned about are those that show up as teenagers with ARVC. If you show up with ARVC and you're 40 when it first shows up, you've already made it 40 years and ARVC is just showing up. You probably make it the whole way without getting heart failure. But if you show up and at 16, 17, 18 with pretty severe ARVC, what we're seeing is that 20 years later, there's a very good chance you're going to be thinking about a heart transplant or that's going to be looming in your future. The only thing we know for sure that's going to change the trajectory is the exercise piece, not exercising or not, more than walking, golf, yoga kind of exercise. I think there's very good data from all over the world that in the slide that I showed you of those people that were non-athletes that had a mutation, none developed heart failure. So, one of the individuals who was involved with helping get our program started, right from the beginning, I said, don't exercise. He didn't exercise, and there's been zero progression of his ARVC for all these years, 22 years, whatever else. So I think the exercise piece is unbelievably important. I think beta blockers probably also play a role, but that's less proven. And then ACE inhibitors, we use them, but there's no specific data saying they make a huge difference. So I think the only lever we have to pull is the exercise level, and that's the lever, and that's why I'm such a, I'm so fixated that's really critical. And we aren't saying you can't exercise for the rest of your life. We're saying take a sabbatical till we can figure things out and come up with some better treatments so we can prevent it progressing in you when we learn more how to prevent it from progressing with some novel medication or something down the road.
So you mentioned exercise, and we always get questions about what's the recommended cutoff or heart rate that you should remain under? Can you comment on that?
Yeah, I don't like that concept at all of saying you should keep your heart rate below a certain cutoff, because one, most patients with ARVC will be on a beta blocker. Beta blockers blunt your heart rate. So if you're on a high dose beta blocker, you can really be exerting yourself a lot without your heart rate going up very much. But that doesn't mean you aren't exerting yourself more than is good for your heart. So I don't like telling, I never tell patients you can exercise, keep your heart rate less than 120. I think the more important thing is think about levels of exertion. If you're running flat out, that's a 10, and lying in bed is a 0, and you want to be conducting your life in the 0 to 3 with periodically going to 6 or 7, but not on a regular basis kind of thing. But I think the whole notion of saying your heart rate can be keep it less than 120 or less than 110 or less than 130, there's not a shred of evidence saying that helps anything. And it sort of encourages you to do what you're not supposed to be doing, which is exercising, going to the gym, going to an exercise machine that's reporting these numbers out. So I think it's, we've had a lot of our patients are superstar athletes. And a lot of them really take this seriously, and they give up their baseball or their soccer and they take up golf, and good for them. That's what you should be doing. And but this heart rate stuff, I think, is misguided personally.
Back to some heart failure questions. Dr. Tandry mentioned to me that you were developing a predictive means to determine heart failure over time through an exercise test. And I'm assuming we're referring to the CPET. Can you speak to that?
Yeah, Brittney, do you want to take that?
Yeah, so I think the biggest thing that we're really realizing over the last little while, and Dr. Calkins alluded to this earlier, that we're really realizing over like the last maybe 5, 6, 7 years, that heart failure is really becoming the current big issue for our patients, because our arrhythmia techniques are getting so good, and ablation is good, and sympathectomy is good, and all these things at controlling arrhythmias are really good. And so our patients are not having so much arrhythmia issues, but they are developing heart failure. And many times our patients were developing significant heart failure when the imagers would look at their echo and say, but their function is normal, but their function is normal. And so we really realized actually that you can't rely on traditional heart failure metrics of ejection fraction to predict heart failure in our patients. And what we actually found is that a metabolic stress test, or a CPET, is much better at predicting and helping us track early heart disease in our patient, or heart failure in our patients, because what it's actually measuring, it's a CPET is different than a stress test, because you wear like a mask while you're doing it, and they're measuring oxygen, CO2, things like that. So it actually gives us a lot more data about detecting early heart failure and tracking it, because something that we have really noticed is that if our patients are going down the heart failure route, there's a lot of things that we can try to throw at it to turn it around. But if not, it sounds really scary, but we do want to get our patients evaluated for transplant sooner rather than later. And our patients are otherwise usually very young and healthy and can do very well through the transplant process. So the biggest thing that we're pushing is don't wait for that evaluation until it's too late and the heart failure has backed up into other organs and things like that. So it's just one more push. And I tell my patients this all the time, because ARVC gets really binned into this world of only being followed by electrophysiologists. And I love you, Dr. Calkins, but electrophysiologists sometimes do not think about heart failure, especially nationwide. At Hopkins, of course, we're always getting Dr. Galotra involved, but that our patients should be followed by a cardiomyopathy physician as well, in addition to their EP.
Can you have ARVD but not have VT? The short answer to that is yes. You can have VT. You can have ARVD and not actually develop sustained runs of VT. Is it common for ARVD patients to develop AFib?
The answer is yes. That again, this is one of the things that has changed over time. We used to think that ARVC spares the atrium and that atrial arrhythmias were not part of the disease. We now know that about a third of patients will develop atrial arrhythmias, either AFib, aflutter, atrial tachycardia. Over time, it's again usually patients in the later stages of the disease. It's not an early manifestation, but absolutely patients with ARVC can develop atrial arrhythmias. And we've just put together a paper looking at catheter ablation in patients with ARVD, catheter ablation of atrial fibrillation. It appears to be effective.
Here's a question posed by a young person in their 20s, diagnosed a year after sudden cardiac arrest, had 2 ablations, and is taking metoprolol and sotalol, but physicians are now discussing taking off sotalol because of long-term side effects. So I don't know if you want to comment about sotalol versus possibly other antiarrhythmics.
So sotalol is one of the classic antiarrhythmics used in ARVC, and it does not have long-term side effects. I mean, amiodarone has long-term organ toxicity. It can affect the liver, lungs, and thyroid. So amiodarone is a medicine we really like to get people off, for the long term because of its organ toxicity. Sotalol doesn't have organ toxicity. The problem with sotalol is a lot of people feel lousy as soon as they start taking it. They feel tired and just feel lousy. Some patients tolerate it very well. Whether you need both a beta blocker and sotalol is unclear. I mean, and it may well be all you need is a beta blocker, stop the sotalol. And most people that use sotalol underdose it anyhow. They use 80 milligrams twice a day, which is really no more than a beta blocker anyhow. So if you're on that kind of low dose, you might as well stop it because it's just cost with no real benefits, just the same as taking a little more of the beta blocker.
So Brittney, here's a good question for you. Is heart failure more common in certain gene variations? And then can you also comment on like subtypes? So like PKP2 carriers are more likely to present like, for example.
Yeah, so it's really, we're getting into a really exciting time in ARVC that we can start having these what we call genotype-phenotype correlations. And so instead of managing all of our ARVC patients the same, we can manage you based on your specific gene subtype, because we do see a lot of differences between PKP2 and desmoplakin especially. The PKP2 tends to be much more arrhythmic. Desmoplakin tends to present with a lot more heart failure. Our desmoplakin patients were a lot more worried about structural disease. They tend to present more left-sided, with left-sided dysfunction than right-sided or biventricular. So we see a lot of differences there. Progression-wise, we're getting into, we're starting to understand a little bit more about that. And I'll kind of save comment on that until we have some more hard data rather than just saying what I see anecdotally.
Where does dancing stand in the scale of safe activities? And I think this really depends on the exact type of dancing, the intensity level, how long we're doing it. So we have a pendulum that has all kinds of activities listed. Is it listed here?
Yeah, the Met thing.
Wait, but it doesn't have dancing.
Not dancing, but we have a larger thing that we could look at. It gets very specific, so it depends.
And I think that really gets into something that I always like to comment on after Hugh scares everyone and tells everyone never to do anything except for yoga, golfing, walking, and sex, I think are the only 4 things you allow. But I always do comment that exercise is a broad term, and there are safe activities that you can do because we want you to have a high quality of life. And I would really encourage you to talk with me about a safe exercise program because yes, broadly, endurance exercise is bad, intense exercise is bad, but you can still be an active person without putting yourself at risk of danger of progression of your ARVC. And then we can't necessarily get into in a broad talk of, can I do this very specific activity, but I'm happy to talk to you individually.
And Hugh, do you want to comment about scuba diving? Besides the risk of being shocked underwater, you know, recreational versus I'm a scuba diver instructor?
Oh, I mean, everything has risks. I mean, obviously, the theoretical issue with scuba diving is if you're down there 80 feet below the surface and you have VT or VF and you pass out while you're scuba diving, you know, you're going to have a buddy there to, whatever. It'll be a little bit of a difficult situation. That said, scuba diving tends to be fairly relaxing and a placid, peaceful world down there. At least last time I went scuba diving, it's kind of really a great feeling. And so the chance of you having a cardiac arrest and having sustained VT while you're 60 feet under is pretty darn low because you're like mellow. But I think it all comes down to nothing is perfectly safe. And it comes that Brittney said, quality of life is important. And if you like scuba diving, that's one of the things that you really enjoy. It's certainly not bad from an exercise perspective. I would say scuba diving fits right on that chart at a pretty low, is a good thing to do. I think scuba diving is just great to do. And yes, you have to say if you have a bad event when you're down there, it could be bad. But if you love it, I personally would, I encourage people to follow their passions as long as they aren't high level competitive endurance sports.
What are your thoughts on people being able to eventually wean off medications?
Oh, I think the one medication I feel the most strongly about, as you know, is beta blockers. And beta blockers are the only medicine that have been shown to prevent sudden death and prolong life and prevent heart failure. And they're simple, safe, with almost no side effects. And the dose range varies widely. So I think everyone with ARVD, unless you have terrible asthma and can't take it because of your asthma, should be on some degree of beta blockade. I think it would be silly not to be on it. Other than that, the other medications, none of them are well founded. And the only scientific data we have is exercise, and beta blockers to some degree, and nothing else for anything other than that.
Someone asked about us seeing patients given the COVID pandemic and offering telemedicine, and we are open for business. We are seeing patients in person. We are also seeing patients via telemedicine where state licensure laws allow, and it varies state by state, and it varies on a month-to-month basis. So we do have some temporary licenses in some states. There's some waivers in some states. So you can always reach out to myself or Brittney to see which option's best for you. But we are seeing patients. The hospital is very quiet. Things look different, but we are open for patients.
But it's amazing, like this telemedicine, this licensure, you would think it would be allowed all over the country. It's so good for patients. It's so good for care. And yet certain states, you just can't get a license to do this telemedicine. It's really unfortunate.
Are troponin levels consistently high or elevated in ARVC? And is this indicative of further damage or progression?
So, we have not done a huge amount of research on biomarkers and troponin levels in ARVC. We do know that after you've had a shock, it's very common to have a troponin level, and that during a hot phase, you can have a troponin level and troponin leak. In some people that have this sort of myocarditis picture, particularly desmoplakin mutations, they show up with chest pain, they have a troponin leak, it's sort of this hot phase, they're sort of leaking troponin. I mean, clearly that can't be good. I think you'd prefer not to be leaking troponin because that means there's some degree of ongoing cell death, not necessarily a lot, but some. But the data we have right now that's come out of Italy suggests that the hot phases do not appear to be a high arrhythmic risk state. So it's not so much that you're leaking troponin and you're suddenly going to have a bad arrhythmia then. Whether the leaking of troponin will enhance your risk of heart failure long-term, we just don't know. So again, an active area of investigation and much more to learn.
It's Hugh or Brittney. For family members with a PKP2 positive test who have a sibling with an ARVC diagnosis, what's the likelihood of developing ARVC in the future?
Well, I'll just say it depends if they exercise competitively or endurance sports. If they do, then it's 85%. And if they don't, it's probably less than 20%. Brittney, what do you think?
Yeah, and that's the tricky thing about PKP2 especially. I mean, we have worldwide repeated fantastic data replicated in every ARVC center around the world that exercise is the strongest environmental modifier in PKP2 patients. So it's widely variable, and a lot of it depends on exercise. Sometimes it doesn't. We have tricky cases where the exercise doesn't seem to matter. Last March, we were supposed to be launching a gene modifier study and collecting saliva samples from a bunch of people to try to find these genetic modifiers that may protect some people. Obviously, we were not really allowed to go taking a bunch of spit from around the country, but hopefully we will have permission to launch that study again soon, because we know that there's more to it beyond exercise. We're trying to understand, but on average, we know that it's about a 50% risk. So if you have a PKP2 variant, if you put blinders on, it's about 50-50.
Yeah, the thing about Brittney said is curious is that we've looked at this and we have some patients that have a mutation that exercise a huge amount and get away with it. And what they have that other people don't, we really want to know, because that could really be unbelievably important in cracking this mystery. And so this was the study we were going to do that got shut down by the virus, but we hope to get it done at some point.
Brittney, maybe you're younger than me. Maybe you have more input on this. When kids are off their insurance, parents' insurance, which I think is what, 25 or 26?
Yeah, I saw this question.
Okay.
Yes. I was like, what? I'm not that young. Yes. So, yes, ARVC is a pre-existing condition. The genetic mutation is not. We can get into that later. But the diagnosis of ARVC, if you have ARVC, it's a pre-existing condition. This is why, a lot of us who follow kids with genetic heart conditions thought that legislation like the Affordable Care Act, which provides protections for pre-existing conditions, is really important. So as of right now, those protections for pre-existing conditions in the Affordable Care Act have not gone away. So they are still there. And so an individual with a pre-existing condition would still be able to get insurance on the open marketplace. It is, with any pre-existing condition, likely to be more expensive if you have a pre-existing condition. I will say, however, if you go to work for a group company, a company that has group insurance, for example, when I came to work at Johns Hopkins, nobody asked me to see any medical history, nothing. I was just put on the insurance when I started. And so most employer run health insurance would never be an issue for patients with ARVC when they get off their parents' insurance. So it's only if you're going out and purchasing your own policy where you run into issues. But yes, right now, the Affordable Care Act did extend the ability for kids to stay on their parents' insurance until they're 26. If that answers the question.
I think so. Yeah, that's what I was getting at. So there's been a lot of talk about the iPhone 12s and how they can interfere with the ICDs. And I was just talking with our device nurses earlier this week about it and looking on Boston Scientific's website. So I think because of the new antennas they're using, it's like a stronger magnetic force. I think they're still trying to figure out what the risk is. But here at Hopkins, we continue to recommend that you not place your phone in your chest pocket near your device and use it on the opposite side when you're talking. And that's all I know. Hugh, I don't know if you have any more to add to that.
No, I agree.
Okay. Can you explain the difference between beta blockers and antiarrhythmic drugs? And like, what are the common ones people are on?
Yeah, I mean, beta blockers block adrenaline. They block the sympathetic nervous system. Antiarrhythmic drugs are drugs that work on the ion channels of the heart, sodium channels, potassium channels, calcium channels, channels other than sympathetic channels. So antiarrhythmic drugs are like sotalol, flecainide, Tichnell, amiodarone. Beta blockers, toprol, corag, timolol, nadolol. There's a huge number of beta blockers. Bisoprolol.
And someone asks about irbesartan, which is an ARB, right? That's not really a substitute for a beta blocker.
No,
Yeah,
that's one of the heart failure medications, either an ACE or an ARB, like lisinopril would be an ACE and ARB would be Avapro, that kind of thing. Irbesartan.
Is there a strong correlation between diet and risk for symptoms, focusing on like caffeine, alcohol, things like that?
No, caffeine is generally felt to be safe, so that's not an issue. Alcohol, there's lots of studies saying alcohol in high levels is a toxin to the heart. So you can develop, if you're an alcoholic, that can give you a cardiomyopathy. Any level of alcohol can increase your chance of developing atrial fibrillation. The chance of alcohol affecting VT, I think, is less, but there. But yes, alcohol has some negative effects both on the heart function, but heart arrhythmias, but it's usually dose related, and alcohol and moderation is fine.
So a couple of people are wondering, when you're in the midst of a shock storm and you're in the ER and the ER doctors don't know what they're supposed to be doing with you, are there general medications that they should be giving to calm things down? Sounds like people have had experiences when no one knew what to be doing.
Well, they should, they can stop your defibrillator from shocking you by putting a magnet over it. So all emergency rooms have a magnet they can put over the defibrillator that will inactivate it. Now, if you're having a life-threatening arrhythmia, they obviously don't want to inactivate it for too long. But then it's standard resuscitation in terms of management of VT. So any emergency room, they should be well trained in IV amiodarone, IV lidocaine, the different antiarrhythmic drugs that you use in that kind of situation.
There was an earlier question someone asked about accessing device data. As far as I know, patients don't have direct access to their device data. Do you think that will change in the future? I mean, I know we're always willing to give people copies of things, but as far as electronic access.
I mean, there's a big trend for patients getting more access to their own medical records. So at Hopkins, they have, My Chart or whatever else where patients can go in and look at all their medical records, from home or whatever else. And this is, it brings up all kinds of questions. A patient sees an EKG and wonders why the EKG says it has X, Y, or Z. And of course, they've been that way for 20 years. So but that's the movement. And in terms of device, you have remote interrogations, getting that advice. There's a lot of discussion about, is it a good thing? Is it a bad thing? I think in general, the movement is more information to the patients. So I would think within 5 years, when you have a download, you'll have a portal to go see it yourself, but it's not quite there yet.
And Brittney, maybe you can help me with this, because for the life of me, I can't think of the term. A study on like the genetics related to specific medications, where like certain people are profiled as certain drugs being more beneficial or processed more quickly. What's it called?
Pharmacogenetics.
Yes, thank you.
Yeah. So pharmacogenetics is really emerging as something that's really important. It's still in the the cardiology community a little unsure how we use it. There is possibly some data that there's one common genotype that may impact how you process certain antiarrhythmics, like flecainide, for example. So sometimes if we find that patients aren't really responding to a certain dose of a medication that we think that they will, I have had some of our doctors order this genotyping. It's much more used, I find, in the pediatric space than in the adult space, anecdotally.
And I don't know if either of you, there was some discussion about medications that the subtitle didn't spell correctly. Someone was wondering, I don't know if you saw that, whether it was sotalol or flecainide. I'm wondering if it was one of those. I don't know if you saw it, Brittney. but you can email me directly. Any specific vitamins or foods that are recommended to help improve heart function or just reduce symptoms in general? Not that I'm aware of.
Yeah.
No, eat a healthy diet and
Healthy, balanced diet is generally what we say. Any big questions you think I missed, Brittney?
No, that's why I wasn't listening to you, because I was going through the questions, but
Okay.
well, we generally say
very
avoid smoking, overeating, or over drinking.
Right.
That's general good words of advice. Good.
Yeah, I
Also,
think we got an overview of a lot of the broad questions, and we can talk more in May.
we will talk more. We have an outstanding lineup with over 15 people internationally, experts in ARVC who will be joining us. Those talks will be recorded, but you will have to register through that platform in order to have access to those talks. So it won't just be posted right away, but will be available for about, I think, 6 months afterwards. All right, finally someone asked.
I know, I can't believe we got through an hour and a half without it, and it snuck in at the end.
COVID vaccine. Thank you, Dina and Tori. So COVID vaccines, any concerns with our ARVD folks getting the vaccine or getting COVID?
Well, don't get COVID and get the vaccine instead.
There you go. No, I really haven't heard of any issues. We've been vaccinated. I was fine. Brittney whined.
I was very sick, but no, it lasted 12 hours. But
Expected.
not whiny. But I think importantly for our patients, yes, you should definitely get the vaccine. Cardiomyopathy patients are listed in most states as a pre-existing medical condition that puts you at higher risk. Every state, however, is completely different where that falls in the lineup. For example, in Maryland, we're not even there yet. And so it's completely state-based. So if you ask me when you can get the vaccine in California, I have zero idea or control. So it's very state-based, but if you are our patient that we follow closely and we've seen you recently, we're happy to provide evidence of your diagnosis of a certified letter. But yes, if you can get it, get that vaccine.
Yep. And I think we did it before 9.
You did it. Perfect. I want to thank you on behalf of the SADS Foundation. I really appreciate the Johns Hopkins team for sharing all their knowledge. Very informative. We've had several comments and very appreciative of that. So, and I thank all the families that have joined us tonight. We appreciate you being here. So with that, I'll say good night. Thank
Good
you
night,
all.
everyone.
Thanks so much. Stay safe.
See ya.
Bye.